Good afternoon, everyone, and thank you all for being here. And first and foremost, welcome to our Google Hangout on the proposed Medical Innovation Bill. A bill that's interesting and important, but hasn't been void of controversy, I would say, with some describing it as pioneering and even groundbreaking, whilst some have expressed some concerns, including myself, and some would even go so far as to say it was potentially dangerous, and then we'll find out whether that really is the case. Now, my name is Dr. Ranj Singh. I will be hosting the discussion today, and I will be posing some of those difficult questions and seeing how we can explore this bill a bit further. We're going to be debating the bill with a panel of different people, some experts in various fields of medicine, some representatives from charities and patient groups, and everyone has their individual perspective on the bill, and it would be really good to hear that.
Let me explain first, if I may, Dr. Ranj, how the bill achieves the first purpose, which is to encourage medical innovation. It does that because the proponents of the bill and many of the advisors from the judiciary and from the medical profession have pointed out that the current law can be perceived as acting as a barrier to innovation and inhibition to progress. If that view is correct, and it is the view that we take, it means something very stark, which is that all cancer deaths are wasted lives. That is because the deceased receive only the standard procedure, so that science does not advance by 1 centimetre as a result of all these deaths. Why is that? It's because under current law, any deviation by a doctor from standard procedure is likely to result in a verdict, if anything goes wrong, in a verdict of guilt for medical negligence. Why is that? Because current law defines medical negligence as deviation from standard procedure. The next question, which obviously arises immediately, I hope I'm not talking too long, is that, well, fine, if the doctors are going to be more free to deviate from standard procedure, then how are people to be protected from reckless experimentation? The answer to that is that the proponents of the bill believe that the bill does a better job of protecting patients than the current law. That's because it says that any proposed innovation has to be approved in advance by the multidisciplinary team in the hospital, which now in all hospitals, in all cancer cases and other complex diseases, is responsible for the treatment and care of those patients. So that's a very high test. Some people have said it's even conservative, but it follows the principle of 2 other important acts of Parliament, the Abortion Act and the Mental Health Act. In both cases, the law says that these are so serious that no one doctor alone can be allowed to carry out an abortion lawfully or to section somebody in a mental health institution lawfully. Those acts can only be carried out by 2 doctors' authorizations. This bill goes further because it says that the whole of the multidisciplinary team must approve the innovation in advance. Therefore, the proponents of the bill believe that it does an important change that will encourage responsible innovation, and that it does so in a way which is safer for patients than the current law allows.
Since the 1990s, evidence-based medicine has really become the norm in the UK and across the world. Since then, clinical practice, hospital managers and commissioners have based much of what they do on these evidence-based guidelines. And in an ordinary hospital, outside a teaching centre, innovation outside the standard treatments or trials is often frowned upon and looked down upon. Now, the Bolam case, which sets the case law for medical negligence in this country, was heard in 1957. 4 years before that, Francis Crick and Jim Watson made their seminal discovery in their paper in Nature called the molecular structure of nucleic acids, a structure of DNA. And I think we all know where that has gone. And over the past 6 decades, we have seen an enormous explosion in our knowledge of science and how it contributes to disease processes in mankind. So these molecular changes have now been mapped or are being mapped for many common disease processes. Our ability to design new drugs aimed at targets in people with disease is now unimaginable compared to what they would have thought back in the 1950s. Yet the case law for medical negligence remains unchanged. And so current law has created a culture of defensive conservatism, stifling innovation. Surgical innovation has also had its ups and downs. For instance, the development of keyhole surgery in the 1990s was put back by almost 10 years following the unexpected death of a patient whose husband happened to be a QC. And so since then, we've had real problems in surgery in innovating successfully and quickly. And so the current president of the Royal College of Surgeons, Norman Williams, recently wrote in the Royal College Journal, Royal College of Surgeons Bulletin, about protecting the patient and nurturing the innovator. Now, some of my colleagues have rightly raised concerns about protecting patients, but there are safeguards within this bill to protect patients from mavericks and quacks. So I believe that this bill will redress the balance and change the culture of defensive medicine and restraint by randomised trial. And as the godfather of randomised trial, Sir Bradford Hill said, any belief that the controlled trial is the only way would mean not that the pendulum had swung too far, but that it had come right off its hook.
We're in a situation now where the scientific endeavours that were referred to by Mr. Chan are bearing fruit in that new drugs are coming onto the market almost on a month-by-month basis, targeting specific molecular signatures that make the cancers occur. Commercially, those drugs are brought onto the market mainly to treat adult cancers of one sort or another with that particular molecular signature. But the commercial marketing of these drugs doesn't include cancers with the same molecular signature other than the common ones. So in childhood, there are a number of situations where there are licensed drugs for adults which have not been tested in children, and because of their rarity and commercial lack of attraction, they may never be formally tested in children. Those situations when somebody is very ill and dying represent a gulf of belief. On the one hand, we say, well, your child has a signature that may be amenable to drug attack, but we can't get access to that drug, even though it's licensed, because it's not licensed for your particular type of cancer. And what is more, it's very unlikely to be with the current environment. So I feel that relieving the doctors of the restraints that currently exist would be an enormous step forward. And I believe that many aspects of the Saatchi bill would allow this to happen, particularly if we're allowed, as Lord Saatchi said, to allow the multidisciplinary team to say, yes, this patient should receive a personal trial of this drug. And if we were able to record that information in an open access database so other people could find out about it as soon as it had happened, then I think that would encourage learning as well as reduce the restraint on doctors. So I'm in support of the bill for those reasons.
My name's Alex Smith. I'm the founder of Harrison's Fund, and we're a charity dedicated to fighting Duchenne muscular dystrophy. Duchenne is something that my now 7.5-year-old son has. He was diagnosed at 4.5, and Duchenne is a fatal muscle wasting condition. It affects every single skeletal muscle in the body, and over time those muscles get weaker and weaker, and most children, it's 99% boys, 1% girls, but most children are in an electric wheelchair by the time they're 11, often needing full-time care and ventilation in their late teens, and many don't make it out of their early 20s. So it's catastrophic. It's a terrible condition, and at the moment we don't have any treatments or any approved cures as of yet. We had some very good news from the US yesterday that there is a pathway for a particular drug in America that will help us, but at present that's not going to be available here. The idea of getting treatment of any description to our children and to those that have Duchenne is just amazing, because at the moment we don't have any. Now, there are drugs out there that would probably prove efficacious and show clinical benefit to children and young men like Harrison. A really good example of such would be Viagra. We all know what it does. It improves blood flow. Boys with Duchenne need to minimize oxidative stress on their muscles. Viagra would allow extra blood flow to their muscles and help delay that oxidative stress. So for me, the idea of doctors being able to prescribe drugs that are available, perhaps that have been approved safe in other diseases, that we can show data and clinical benefit to boys with Duchenne, would be a world-changing, history-making moment for us. And I absolutely support it, and I urge everyone else to support it as well.
Great. Well, thanks for inviting us along. I'm here flying the flag for Empower Access to Medicine, and for those of you who don't know us, it was set up by a businessman called Les Halpin, who was diagnosed with motor neurone disease back in 2011, and set up the campaign in 2012. When Les set up the campaign, he set out very much with a blank slate and just went out to all the experts out there to see what differences could be made to the drug approval process so that it might be sped up to get more innovative drugs to patients faster, such as himself. Unfortunately, Les lost his battle with motor neurone disease in September last year. However, shortly after he passed away, we had a great breakthrough with the early access scheme, which is hopefully going to see more innovative drugs brought through faster from smaller pharmaceuticals. And we were very proud to have hosted a parliamentary reception a couple of months back, which celebrated the launch of this scheme. And obviously we encourage as many companies as possible to come forward with any drugs that they think might benefit from this scheme. For Empower, the Medical Innovation Bill is incredibly important because while we have been looking at sort of seeing the clinical trials process reformed and changes to the market so that drugs companies can get their innovative medicines through faster, fundamentally that won't make any difference unless doctors have the freedom to be able to prescribe drugs as they see fit and appropriate to their patients. So it's that bedside innovation that the Medical Innovation Bill will hopefully provide, and that's why we absolutely support it.
A lot of legal professionals are arguing that current case law already protects the doctor who wants to innovate, providing a reasonable number of their peers would agree with them. And the reason that's put in place is because it does offer some sort of safeguard to the patient already, and the doctor is already under professional and, you know, obligations from the medical point of view to do that. So there is already law in place. What does this bill actually change?
Under current law, the doctor is obliged to anticipate in advance, to speculate in advance about whether he will or won't have a body of responsible persons skilled in the particular area of medicine in question who will appear to defend his decision to depart from standard procedure. The reason this bill makes an important and very simple change, that what I just described is called the Bolam test, from the test case that Charlie Chan spoke about. The Bolam test now takes place after the event. In other words, the innovation has been attempted, something has gone wrong, there's then a trial. This bill brings the Bolam test forwards. So the same test, which you rightly say, Dr. Ranj, is a good test, which is this innovation supported by a responsible body of medical persons? At the moment, that test takes place after the event, and the doctor has to be extremely anxious about what will happen after the event. The Bolam test in this bill is brought forward to before the event, so that the doctor can have complete certainty about whether the proposed innovation is or isn't one which is lawful.
We'll pick you up there. There have been some legal professionals and medical professionals who have expressed a concern that the bill allows a doctor who believes something may work for a patient to offer that treatment with the patient's consent, quite rightly, but with no agreement from any peers or fellow professionals. So therefore, in essence, promoting a maverick doctor, a maverick practice. How are we going to prevent that happening?
Well, the bill prevents that happening, and the bill prevents that happening by requiring that the multidisciplinary team in the hospital has to approve the innovation in advance.
Is that in the wording of the bill? Because I'm not a lawyer, but reading the bill, I don't know if it specifically stipulates that that must happen or that may happen.
I'm going to tell you flat out, Dr. Ranj, you're making a really important point.
Yeah, I think so, because I think these are the things that people are concerned about.
You are making a really important point, and when I quote the Department of Health saying, and the Secretary of State saying, we want to learn from this consultation.
Absolutely.
This consultation is not just sort of some sideshow. And one of the important things which has been learned is that the clause in relation to the multidisciplinary team will say, when this bill is announced in Parliament, that it's a must.
Okay.
It's not a might.
Good.
It's not a maybe. It's not related to what's in the mind of the doctor. It's a must. The multidisciplinary team in the hospital must approve, and the drafting will say exactly this, must approve the innovation, and furthermore that the innovation must be reported to the doctor's senior responsible officer, all doctors now have one, as you know, in advance.
Okay.
So therefore the doctor has to pass a very high test. As I said, it's higher than the test for abortion and mental health.
Okay.
So the doctor has to pass the Bolam test. Instead of worrying about whether he will or he won't later, he can pass the Bolam test in advance. Do you see that gives certainty to the doctor?
Has it actually changed so far since its initial, the initial writing of the bill? Has the bill evolved at all, or is it still, does it still stand as it originally did?
No, it has evolved, and I think it will evolve more as a result of this consultation. What the Secretary of State said with the support of the Prime Minister last November was that the government was planning to move forward with this as a government bill and introduce legislation at the earliest opportunity, provided that the consultation was successful. And so far, as I understand the latest figures, of the 15,250 people who have responded to the consultation, there are now only 17 of those which are against the bill. I think the reason why the bill has gained so much support is reflected in remarks made by Professor Kennedy at Oxford recently about the bill. He put it this way. He said that what patients and their lovers, mothers, daughters, sisters want to know is, has everything been done? Is there anything else that could be done? Is there anything that we can do? That's what people want the answer to.
I'm going to go to my colleague on my right in a minute, but Professor Baum himself, Professor of Emeritus Surgery, I'm sure you know him at UCH, who has had 50 years experience in research on breast oncology and surgery, and he says that never once has he encountered interference or obstruction on legal grounds, and he has pioneered or innovated, you could argue, on various different fronts. The bill itself doesn't have full support of royal colleges, as far as I'm aware. Even the MDU itself says it is not necessary. So why is that the case? Why do you think the royal colleges, the RCPCH, the Royal College of Physicians, and why do you think, and the RCOG, for instance, why do you think they're not behind this bill?
Well, I think there's 2 points there. First of all, I think the comment from Mike Baum, really asking whether, in fact, innovation is currently inhibited within the structure we have. And I think I would turn around and say, it depends where you are. I think Mike has had a really illustrious career, and I respect him enormously. And he's a great friend. And he has heard Lord Saatchi speak as well about the bill at the Royal College of Surgeons last November. Now, I think it'd be true to say that if you're in a teaching hospital or of an ivory tower, there will be ways in which you can get past the standard test and the standard treatment, in the sense that you will have ethics committees and trial groups and so on who are there all the time, whom you can go and consult, not perhaps at will, but very quickly. However, if you go outside the teaching hospitals and go out into the community, into the hospitals and the normal towns in this country, there is no mechanism for which you can actually engage people to discuss these innovations on a regular basis. And so I think it's true, there are people who object, and they tend to come mostly.
But these are very prominent people that are objecting,
yes.
And these are, and you're almost saying that actually it's not innovation that's the problem, it's the sharing of information, it's the dissemination of information, and maybe we should change that.
It's the culture as well, because I think the thing is that within normal hospitals you will find that treatment pathways and so on are often defined by evidence-based guidelines.
Yes, and there's reasons for that,
and
isn't
there? Reasons for that.
And there's safeguards.
Absolutely.
It's ideally promoting best practice, isn't it?
Absolutely. But I think what this bill comes to is not about those patients whether you follow the guidelines. It's about those patients where you have followed the guidelines and you've fallen off the edge. And that's the thing about this bill, because it is not about substituting new treatments for existing treatments. This is about making sure that those patients who've had all the standard treatments that you can for your disease, and there may be many or there may be none, all right? But those patients where there is nothing else and where you are at the last chance saloon, then those patients should be offered the opportunity of having responsible innovation. So yes, there are safeguards there, but they don't really apply to these people because they run out of things. They run out of other things to do.
Professor Walker, I want to get your opinion on something. One of the biggest concerns that myself and many professionals have around this sort of legislation is, for instance, particularly in your field with childhood brain and spinal cord tumours, some may be aware of the practices of a doctor called Burzynski in America, who, if, you know, some people are quite rightly concerned that this bill will promote that sort of practice in the UK. Now, Burzynski is running what, you know, he calls clinical trials, innovative clinical trials, using novel compounds, which he has termed anti-neoplastons, and essentially trying them out on patients with agreement of a multidisciplinary team. The problem is, couldn't that sort of situation happen here? What's preventing that from happening in the UK then? Most self-respecting medical professionals in this country do not agree with his processes and they do not agree with his findings or his practice. How are we going to prevent that happening in the UK?
Well, I do know quite a lot about Dr. Burzynski, and I've watched the TV programmes and I've been involved in the consultation.
And some of it's quite shocking, some of the practices that are happening over there, and we don't want to see that in the UK, do we?
I don't think that the American Medical Association particularly like what Dr. Burzynski is doing, and he's under intense pressure to change his style. And I think it would be distracting to discuss that particular case because he's actually a unique individual because of the drugs, they aren't drugs actually, the chemicals he's offering.
They're chemicals, exactly. But some could argue he is an innovator and could use the law or legislation around innovation to do something like that here.
He has used that argument over 20 years that he's an innovator.
And he's been allowed to do so.
To date, he has not published any evidence of the benefits of the...
We don't want to see that in this country, do we? That's my concern. That's a big concern.
Well, yes. But I think I'd actually just like to check that Dr. Burzynski, as far as I'm aware, doesn't work within a multidisciplinary team. He works within his own institute, funded by himself, and was him as the sole opinion within that institute. And he doesn't meet with other practitioners in multidisciplinary teams, because I know of patients who've gone to him where there's been no debate or discussion with anybody other than his own team. So.
But that's the thing, what constitutes a multidisciplinary treatment? And I think the bill needs to be quite specific on that.
In this country, the multidisciplinary teams for different disease types is very clearly defined within the National Cancer Plan, the arrangements. They're named, they have named chairmen, they have constitutions, they have full lists of people who remember it, their attendance is recorded and reviewed in their annual review plans. So what we're talking about in this country is not Dr. Burzynski's setup.
Yeah.
And so I think that is a confounding and unclear comparison.
Yeah. Sorry, Lord Saatchi, you wanted to add something.
I was going to, in relation to what Professor Walker was just saying, I don't know anything about the man that you're talking about. He sounds like a dangerous quack or maverick or whatever. Maybe he's not, I don't know. But it's not possible. Your anxiety, which is very understandable and correct, which is that people would somehow be able, through being made more free, that you could have quackery or mavericks doing whatever they want. It's not possible that the man who proposes dandelion juice to rub on the tummy of the pancreatic cancer patient, that person is never going to get that through an MDT. So just exactly as Professor Walker said, the multidisciplinary team is not just sort of made up, it's a part of all doctors' validation procedure, as is the existence of a senior responsible officer. So I want to leave you in absolutely no doubt, Dr. Ranj. The bill,
and everybody else.
And everybody else.
Yes.
The bill as presented to Parliament will say that the MDT must approve in advance for an innovation to be carried out lawfully. It will be an absolute objective test. There need be no anxiety in anyone's mind about that drafting, and that the effect of that, I hope you agree, Dr. Ranj, is that it is impossible, more impossible than it is now, impossible for the man with the dandelion juice to take that through an MDT.
Could I make one other point, Dr. Ranj and Lord Saatchi, is that this would become much stronger if there was a compulsion to record the experience for others to find out how well that treatment works.
That's it. That has to be in place.
No, the young people who I deal with who are facing the end of their lives, and I talk to them about entering clinical trials, they and their families want to feel that their experience is something from which others can learn. And I think if we take this step in producing this innovation environment, then one of the key parts of it is to create a learning arrangement so that every case is learned from.
And also, if I may make the point, also, with a large central database, maverick practice, if those individuals did manage to get through, would actually be exposed, because with mandatory reporting, you would see quite quickly the fact that Dr. Burzynski was perhaps using these particular things with no success rate, and doctors could see that, and also if it was open access, patients could see it too, because then patients could interrogate the database at the same time and also make those suggestions to their doctors.
So does the bill itself have a stipulation that the data needs to be collected in a certain way?
No, it doesn't. And there are many people who have said in answer to, well, why not include it on the face of the bill?
To make it a compulsory
thing. It's a requirement. Many doctors have said that this could turn into a bureaucratic nightmare. People have also said, well, who's going to pay for it? I mean, the Department of Health is not slow to say, well, the NHS, where's the NHS going to get the money to pay for this? So this is a real issue.
Absolutely.
This new innovation which is going to happen, hopefully spearheaded by this bill, who's going to collect the data? How are we going to learn from it? Otherwise, everything I've said about the advance of science is not going to apply, Dr. Ranj.
Yeah.
How does this tie into care.data and electronic patient health records? Because surely that provide the mechanism to collate the data as you've described.
Charlie?
Yeah, I mean, I think the whole business about electronic records has been a difficult problem, hasn't it, for the Department of Health over the last 20 years. I remember one of my consultant colleagues who was closely involved with this telling us in 1992, you'll have an electronic record within 3 months. Well, that 3 months has come and gone several times since then. I think undoubtedly having some form of centralised record would enable you to do that, because then you'd have another field in it. But of course, I think an electronic patient record is still going to be some way away for the whole of the NHS. And so I think if this bill is going to become law within this Parliament, then I think it's really important that we have a central data repository. And I mean, you know, I've been talking to Lord Saatchi about possibly housing this at Oxford University, and I have some friends who work there in that particular department, and it would not be a difficult thing for them to do. And I think hosting it in an institution outside the Department of Health hands would in a way actually give it a degree of academic independence, so that people don't see it as a political tool to look at things. If it becomes open source and it becomes owned by the profession, whether it's colleges or whatever, then I think that would really help immensely.
You could argue that rather than pushing forward this bill, we should be speeding up ethical approval processes. We should be bolstering research. We should be promoting translation of research and limiting bureaucracy. That's what we should be focusing on, rather than introducing a bill that may not change much but could potentially put people at risk.
I think the current process that we have for randomised trials and assessment for drugs is really good for patients who have common diseases. Breast cancer, heart disease, diabetes and things like that. The problem comes when you have people who've got rare diseases, because they actually don't really have a trials process that is timely and amenable, because you can never accrue enough people into those trials to actually determine whether drug A is better than doing nothing. And so for many of these patients, there is nothing. There really is nothing. And so I think the thing is, it is quite difficult to apply the same standard, if you will, I won't say standard, but the same process which we use for common diseases to the rare ones. And the thing about the common diseases is that this will apply to those where you've done all the ordinary things, you've done all the trials, and then you fall off the end. And so this is a way that there is a protection there, because patients will not be able to go straight into something novel. They either have to have nothing from this to begin with, or they run out.
For the people with rare conditions, the lack of numbers of people with that particular condition represents a major risk to them. If you happen to get cancer and you get a common breast cancer or a common colon cancer, you have one level of care. But if you get cancer and you have a rare condition such as pineoblastoma of the brain, in adulthood, there's no evidence base for the treatment of that disease in adults whatsoever. There is an evidence base in childhood, and that is limited in itself. And so you then have a condition which there's no evidence to justify the treatment, and where really, if you're going to offer anybody any chance of a brighter future, you have to innovate, you have to take risks. And on the whole, those people will not sue you in the courts if it goes wrong, because you've engaged with them and explained to them the situation.
It's very important for people to look at the culture of litigation which now exists. And shall I give you some basic figures? So
by all means.
Well, these are astounding figures from the House of Lords Library. The NHS last year paid out in claims £1.2 billion. The Treasury, very helpfully, produces a document called the Whole of Government Accounts, which is the nearest thing to a sort of national balance sheet. So there it assesses all the liabilities that the state could have. One of them is claims against the NHS for medical negligence. The current amount which the Treasury has put aside to meet future medical negligence
something like
claims,
40 billion, isn't it?
It's 24 billion pounds. Now, I cannot imagine that you could have a wall of litigation of that kind, whether this is not to do with innovation, that doesn't create a culture of risk aversion and a culture in which the only safe path is to stick to the status quo. That must be the result. That's why so many people have said in support of this bill that we want to change the culture. The Department of Health wants the NHS culture to be less risk averse, more innovative. It produces many documents and people give speeches to that effect. But I think the reason people support this bill is that I think they've seen that you can't change the culture without changing the law, because the law is there and it creates the culture that it has. Therefore, this change is of tremendous significance in terms of altering the culture. That's why so many people support it.
That's if it, I know the Department of Health is consulting. That's if it's implemented in the right way and it has the right kind of impact. Now, we could talk on this for hours and hours, and there are lots and lots of different questions that we still aren't going to be able to answer, unfortunately, in this time frame. But I would urge everybody to go to the Department of Health website and to respond to the consultation, be that positively or negatively. Quite rightly, you should see both sides of the argument. I myself am still undecided which way I'm going, but I think it's important to hear both sides of the story. It's a well-intentioned bill, but obviously needs all the appropriate safeguards to make sure it doesn't cause any harm, and that's the best that we all want. Now, thank you to all of my esteemed and very helpful and very knowledgeable panel members. I'm sorry that we couldn't speak to you all a bit more and get some more opinions and ideas, but it's been really great to have you, and I hope that everyone that's watching and listening has found this very useful as well. So thank you very much.
Thank you.
Pleasure.
Nice to see Alex's son there.